I'd like to now bring to the microphone our second speaker, Associate Professor Yoland Antill. Thanks, Yoland.
Hi, Vanessa. Thank you so much for inviting me to speak tonight. And I will try and share my slides successfully. Okay. So I am going to give you a little bit of an overview this evening on different clinical trials, thinking about different treatments for ovarian cancer other than PARP inhibitors. Claire's given an amazing overview, and I think that through the OCA platform, we've had a number of talks talking about PARP inhibitors, and I'm pretty sure most of those talks are still available. So we're really not going to focus on the use of PARP inhibitors in tonight's talk. We're going to take a step sideways. Okay, so just to remind everybody that there are different sorts of ovarian cancer, and the one thing to remember is that going forward, we are now separating out very different pathways of treatment according to the different types of ovarian cancer that there are. I'm just referring to epithelial ovarian cancer tonight. I'm not talking about germ cell, I'm not talking about the stromal cell or other rare types of ovarian cancer. So Claire's really focused her talk around the PARP inhibitors, which focus around the high-grade serous and probably high-grade endometrioid types, and to a much smaller extent, clear cell carcinomas. But this doesn't apply to low-grade serous carcinomas and definitely does not apply to the mucinous carcinoma group. We know that most women who are diagnosed with ovarian cancer are diagnosed at an advanced stage rather than localized. But we'll see as we move through the talk tonight that depending on the type of ovarian cancer that you have, that it may well, in fact, be an earlier diagnosis, but definitely share different drivers, the thing that caused the very first changes in cells to create the cancer in the first place. In particular, endometriosis has a role in risk for both clear cell as well as endometrioid. And the earliest startup lesions in high-grade mucinous or low-grade mucinous is not known, but we do know that there is a pathway between what we call borderline mucinous ovarian cancer through to low-grade and then into high-grade. But the very first and the risk factors for this rare subtype is not yet known. You can see down here that the genetic changes within the tumour and or genetic causes, hereditary wise, are very different according to these subtypes. So in the past, we have lumped all of these tumours together and we've given them basically chemotherapy with platinum-based chemotherapy and hope for the best. But we know that the outcomes for these different subtypes varies. So the first part of the talk is going to think about immune therapy, and we've been really trying very hard to enable immune therapy to be utilised in ovarian cancer, but it's certainly lagging behind a number of other tumour types. There are 5 different sorts of cancer immunotherapy. So when you're talking about immune therapy, you might be talking about an immune checkpoint inhibitor such as pembrolizumab, or you might be talking about monoclonal antibody therapy. And these are 2 types of immune therapy that we're going to spend a little bit of time about. But in ovarian cancer, there is just starting to be some very early trials looking at cellular therapy using the CAR-T approach to cancer therapies. And we will touch very briefly on the potential for cancer vaccine treatments. Oncolytic virus immune therapy is something that is being utilised in other cancers, but is a long way from being used in the ovarian cancer setting at this time. So if we think about Lynch syndrome or mismatch repair deficient ovarian cancer, it makes up around about perhaps 5% of all ovarian cancers. It's a pretty small proportion of all ovarian cancers. Mostly these cancers will be of endometrioid or clear cell histology rather than high-grade serous, and they are often diagnosed at a much earlier stage. We know from recent studies that around 40% of all of the what we call mismatch repair deficient ovarian cancers have what we call this high frequency of microsatellite instability. So we know that Lynch syndrome is one of the most common of hereditary cancer syndromes, but ovarian cancer makes up a small proportion of the cancer types associated with Lynch syndrome. More commonly, uterine cancers or bowel cancers are the ones that are seen. But the hallmark of these tumours is that the cells acquire multiple genetic changes, what we call a high mutational burden. And it's this lots and lots of genetic changes that can cause antigens to present to the immune system. And we often see immune cells infiltrating in and around the Lynch syndrome type cancers. But not all ovarian cancers will have this accumulated high genetic change. And so potentially not all cancers will therapeutically respond to immune therapies. We know that mismatch repair deficient tumours or microsatellite high tumours have access to immune therapies in other countries as single agent. If we look at some of the large studies that have incorporated lots of different types of tumours, ovarian tumours have been represented in small numbers and indeed show a relatively high response to single agent immune checkpoint inhibitor therapy. It's not yet available other than on a clinical study or for self-funding, but it's certainly a group of ovarian cancers that would potentially respond to immune checkpoint inhibitor therapy by itself without any other treatment. The clear cell ovarian subgroup are also a subgroup of ovarian cancers that seem to have a much bigger response to immune checkpoint inhibitor therapies when coupled with some other agents. If we look at some of the trials, early trials that have looked at immune checkpoint inhibitor therapy and immune checkpoint inhibitor therapy coupled with another immune stimulating therapy, the clear cell cancer subgroups were far more likely to respond than those other ovarian cancer subtypes. This may relate to the fact that these have an inflammatory background and have inflammatory cell infiltrate, but certainly there are a number of studies that are moving forward looking at immune therapies coupled with either a second immune therapy or alternatively with some small targeted agents for the treatment of this, again, smaller subset of ovarian cancers. Again, clear cell more commonly seen in the setting of endometriosis, Lynch syndrome, but interestingly is also the much more common subtype of ovarian cancer in amongst Asian ethnic subgroups. But we know for the majority of ovarian cancers, particularly high-grade serous and high-grade endometrioid, that single agent immune therapies really don't work very well. We know, however, that HRD tumours have a higher tumour mutational burden and therefore potentially have this signal to send to the immune system, and they express PD-1 and PD-L1, which is one of the or two of the biomarkers that have suggested immune sensitivity, but single agent has not been as successful as we've hoped. But if we combine immune checkpoint inhibitors with other agents, then the response to immune therapies seems to increase. Some of the other agents that can increase the likelihood of stimulating immune therapy response, so in other words, your own immune system to actually wake up and see the cancer cells there and attack the cancer cells, include chemotherapy, bevacizumab, which is an anti-blood vessel forming agent or an anti-angiogenic, PARP inhibitors, and other small molecule agents such as lenvatinib or other immune therapies such as CTLA antibodies. And this is just one example of a trial that looked at the combination of a PARP inhibitor with immune checkpoint inhibitor therapy. And you can see the different subgroups here. You can see that BRCA mutant tumours, HRD positive versus HRD negative, you've actually got a larger response across all of these subtypes when you combined the PARP inhibitor niraparib with the immune checkpoint inhibitor pembrolizumab. So this is just one example of where the research trials are going to try and get immune therapies to work in ovarian cancer. Another form of immune therapy are these monoclonal antibodies. And we're going to spend a little bit of time talking about what an antibody drug conjugate is. So mirvetuximab is an antibody drug conjugate. These, I might just move to my next slide. These are incredibly clever drugs where you have the antibody, which is attached to some chemotherapy. The antibody attaches to the receptor on the cell surface and is uptaken by the cell, or the chemotherapy is inserted into the cell, into the cancer cell that has the receptor for the antibody on. The chemotherapy itself causes cell destruction, and when the cell dies, it releases the chemotherapy to potentially affect the surrounding cells, what is known as a bystander effect. So mirvetuximab is an antibody drug conjugate focusing on the folate receptors when these are expressed on the surface of the tumour cells. You internalize the antibody drug conjugate and then the active metabolites cause destruction of the cell. The destruction of the cell leaves this potential active drug to cause destruction of the surrounding cells. So the Serous study looked at mirvetuximab in patients who had folate receptor high expressing but carboplatin resistant ovarian cancer and found an overall response rate of around 30%. With a median duration response of around 8 months. And so these antibody drug conjugates are certainly making themselves known to the market. We do know that the overall response rate was seemingly higher if you had had less lines of therapy prior to coming onto the clinical trial. But we also noticed, curiously, that if you'd had prior PARP inhibitor exposure, you had higher response rate. But certainly this is something coming into potentially to treatment options for advanced platinum-resistant ovarian cancer. But something to think about with all the antibody drug conjugates is that they often have very different side effects, treatment-related adverse events, than you would see with normal chemotherapies or PARP inhibitors or even immune therapies that we have seen in the past. In particular for mirvetuximab is the problem with eye toxicity, and this can be very, very dose limiting. It can stop people being able to continue on treatment. So each antibody drug conjugate has their own special set of unique toxicities. This is an up-and-coming other antibody drug conjugate, UpRi, and there's a whole series of trials that are now looking at the use of this agent with an overall response rate looking very favourable in the early studies where you've got high expression of the NAPB2 receptors. So when you're using an antibody drug conjugate, you need to have the receptors on the surface of the cancer cell for the antibody drug conjugate to work, so where the antibody is able to hook on to the tumour cell. So uplift and upgrade are currently in process, but the next plan is up next, and this will be a large phase 3 study in both platinum sensitive as well as recurrent but still platinum sensitive ovarian cancer as a maintenance therapy. So Claire's mentioned these early phase studies as first line setting of PARP inhibitors, and hopefully in the coming few years that we will see even more than the BRCA1 and BRCA2 mutated ovarian cancer patients being able to access PARP inhibitors, but the HR deficient tumours population as well. So what happens if we have a whole lot of women who've received PARP inhibitors in the first line setting? If the ovarian cancer does unfortunately become active again, could the tumours still be sensitive again in the second line? And one of the more recently published studies in 2021 was looking at this question. If you'd received previous PARP inhibitor, could the tumour respond to PARP inhibitor therapy again? And we did see a response to the PARP inhibitor. It wasn't as great as we'd seen in the first line setting. And we also know that the rate of hematological toxicities and some of the more serious hematological toxicities was more commonly seen when you received PARP inhibitors a second time. Remembering also that BRCA1 and BRCA2 carriers may be accessing PARP inhibitors in the maintenance setting in the breast cancer setting. So if they were to have received PARP inhibitor in the breast cancer setting and then require it for ovarian cancer, this is some indication that this may be tolerable and may be efficacious in that setting of ovarian cancer. And just to finish off, I thought I would talk about low-grade serous ovarian cancer treatment options. This is a rare type of ovarian cancer that affects often very young women. Surgery remains the foremost therapy, but these cancers, despite having high estrogen receptor expression, also often have frequent genetic changes in this what we call MAP kinase pathway. We know that these tumours are often more resistant to chemotherapy than high-grade serous tumours. We also know that they're often resistant to standard endocrine therapies after a short period of time, possibly relating to the activated mutations in this particular pathway. So this study looked at women with recurrent low-grade serous ovarian cancer who had previously received platinum therapy. They were biopsied and had retained their low-grade cellular status. So sometimes when these tumours become active again, they transfer into what we call a high-grade type. And these, in this study, they were looking at the use of an oral trametinib, which is a MEK inhibitor, compared to standard of care options, which included 3 different sorts of chemotherapy and 2 different sorts of oral hormonal therapy. MEK inhibitor is an oral treatment. So the overall response rate was around 26%. So this means their tumours either completely or partially responded, but a further approximately 60% remained stable and didn't progress for a minimum of at least 8 weeks. And this was favourable compared to the standard of care arm. They found a much higher response rate in those tumours that actually had a found genetic change in this MAP kinase pathway. And there were their unique side effects, as you would expect with the trametinib, that was somewhat similar to chemotherapy, but much more than endocrine therapy, but largely these were manageable. So trametinib is a treatment that will potentially overtake some of the lines of therapy down the track for recurrent low-grade serous ovarian cancer. We don't have access to trametinib in Australia yet, but I think the MEK inhibitors coupled with other small molecule agents is certainly where trials are heading in this rare subgroup and often affecting very young group of women. Thank you. I'll stop sharing. Back to you, Vanessa.
Thank you very much, Yoland, for that extremely informative presentation. We have a couple of questions for you. The first one is, are there any upcoming trials for platinum-resistant cancers? Oh, you're on mute.
Yeah, sorry, yes, that's a great question. And yes, there are a number of trials looking at these monoclonal antibody coupled, so these ADC trials. There's also immune coupled therapy trials, so not immune therapy by itself. And then there are also some really interesting studies looking at what we call cyclin E amplified or overexpressed cancers, and looking at small molecule agents that specifically target these tumours.
Great, thank you. And the last one is, what happens if I have a mixed type of ovarian cancer with serous and clear cell?
That's another really good question. We know that often tumours can have a mixture of histology types, but often there will be a predominant one. And when tumours relapse or become active again, it's often the only one sort rather than the combined sort that would recur. So treatment would need to be targeted towards that subtype. So that would be often why your doctor might require you to have a second biopsy, even though you had a surgery maybe 2 years ago and tissue was collected then.
Thank you. We'll just ask one last question. I know we are running short of time, but what are your thoughts on estrogen replacement therapy once chemo has been completed?
Oh, this is a really tricky question, because we know that often women are very young. They were premenopausal at the time of their surgery. And with cancers that are hormone receptor positive, this can often be a tricky question. I know that there have been some clinical trials, or not clinical trials, but some retrospective studies trying to answer this question. I think that for short periods of time, and particularly if symptoms are not tolerable, then the use of estrogen-only replacement in its lowest doses to enable control of symptoms is used at times, but not as standard of care.
Great. Thank you so much, Yoland. We really appreciate your time this evening.